webcast is now starting. All attendees are in listen-only mode.
Hello, everyone, and welcome to the fourth edition of the webinar series. My name is Nicolas Rondeau-Lapierre, and I will be your virtual assistant again tonight. We will wait another minute for everyone to register, and then we're going to go through with a small introduction, and we're going to go and present the talk for tonight on Theranostic. I can see the number of attendees going up. So let's start slowly with just a bit of the technicalities of the platform that you're on right now, which is GoToWebinar. As an attendee, we'll go through a bit of the options that you have as an attendee. As an attendee, you cannot unmute yourself. You are welcome to ask any question at any time in the question section, which will be where the question mark is. Just in a few seconds, you'll see it. Thank you very much. Where the question mark button is, that's where you can start asking a question. There will be a Q&A session after the presentation. So please feel free to ask any question at any time, and we'll answer them in the Q&A after the presentation. There is no handout for this session, so you don't need for that section. And that's pretty much it for attendee. If you do have any question, technical issues, please feel free to ask anything, and we'll get to it right away. So with no further ado, let's present our moderator for tonight, Dr. Jonathan Abele. Dr. Abele, now the floor is yours. Enjoy, everyone.
Hello, everyone. Welcome to the ongoing series of webinars organized by the Canadian Association of Nuclear Medicine, Association Canadienne de Médecine Nucléaire. It is my delight to introduce to you our speaker for this evening, Dr. Stephan Probst. Dr. Probst trained in nuclear medicine at McGill and did his fellowship in oncologic PET-CT at NYU in New York. He is the chief of the Department of Nuclear Medicine at the Jewish General Hospital in Montreal. He has a special interest in molecular imaging and therapy of prostate cancer and has wide experience with PSMA PET. This evening, Dr. Probst will be presenting on the topic Theranostics in nuclear medicine. Dr. Probst.
Hi, so welcome everybody. Thanks for joining our webinar tonight. I'm going to talk to you about Theranostics, and specifically, of course, Theranostics in nuclear medicine. These are my disclosures of conflict of interest. The ones that are relevant for this talk are Bayer, AAA, Novartis, and Progenics. So Theranostics. Theranostics is a cool word. It's a portmanteau word, which describes the pairing of therapy and diagnostics. Now, Theranostics is not nuclear medicine exclusive. There's many examples of Theranostics in medicine in 2021. One that comes to mind is the pairing of, for example, PD-1 immunohistochemistry and PD-1 monoclonal antibodies, for example. But in nuclear medicine, Theranostics has taken a special place and a growing place, and it's come to mean the pairing of diagnostic and therapeutic radiopharmaceuticals. Many people consider Dr. Saul Hertz to be the father of Theranostics. And well back in 1941, at the birth of the nuclear age, he was working in Boston at the Mass General, and he identified radioiodine compounds that were concentrated by the thyroid, first in rats, and he went on to treat the first humans with iodine-131 for both hyperthyroidism and for differentiated thyroid cancer. Theranostics has been described in many ways, but one of the nice, elegant ways that I found it described is by a colleague, German colleague of ours, Richard Bond, who described it this way to a patient, and I thought this was kind of a neat way of describing it. He said, Theranostics is you treat what you see and you see what you treat. And I thought that was kind of elegant in its simplicity. So how many different types of theranostic pairs can we think of? I like to think of pairs in a pair class, if you will. And for me, there's four pair classes. So pair class 0 is not really a pair class. It's the diagnostic is the therapeutic. So iodine-131 is the perfect example. At my hospital, 4 millicuries of iodine-131 is a diagnostic scan, and 30 or 100 millicuries is a therapy. If we were to change just the isotope in the molecule, for example, in I-123 MIBG and I-131 MIBG, the element is the same, but the isotope changes, that would be pair class 1. Pair class 2 is when the isotope and the element changes, for example, gallium-68 DOTA-TATE, lutetium-177 DOTA-TATE, and then pair class 3 is when the element changes and the carrier molecule changes. And an example of that is PSMA-11 and PSMA-617, which are different carrier molecules which form a theranostic pair. The DOTA-TATE pair is probably the newest on the block in terms of clinical approvals. I believe it was approved in early 2019 and has really come online in Canada as a clinical program in many different centers, not just a research application anymore, not just a protocol application anymore. And you'll notice the diagnostic and the therapeutic are identical, except for of course the atom, the isotope, which is in the DOTA carrier. The mechanism of action of DOTA-TATE, which is largely the mechanism of action or analogous to the mechanism of action of all these nuclear theranostics, is most of the time it's administered either intravenously or by mouth, and it gets into the bloodstream, and it travels in the bloodstream, and it finds, in this case, the SSTR receptors. And then the SSTR positive cells, hopefully the malignant SSTR positive cells, will internalize the carrier molecule alongside with the beta emitter, and then the beta emissions will induce cellular damage, and we hope cellular death, to destroy the tumor cells. So what are theranostic first principles? What are the things, if you want to get your feet wet with theranostics, you want to get your feet wet treating a patient, what are the questions that you should be asking yourself? The first question you should be asking yourself is, does all of the patient's disease harbor the target? Are we going to be able to get these theranostic agents into the right cells in the patient? And then the second question you're going to be asking yourself is the expression of the target high enough to allow therapeutic efficacy? This will lead us to the concept of concordance. And concordance, for me, is the fraction of disease volume which is positive on the diagnostic divided by the total disease volume. In an ideal world, this would equal 100%. I don't think there's any doubt in people's minds that if we can treat all of the disease, that's better than treating some of the disease. Of course, defining positivity is something that we need to dive into, and a very important point that I'd like you to consider is that diagnostic positivity does not equal theranostic positivity. For example, the famous Krenning score, which was published by Eric Krenning way back in 2007 and describes the amount of uptake on planar indium oxygen scan scintigraphy, described a categorical scale with 4 different levels of uptake. So any uptake less than liver was a 1. If it was roughly equal to liver, that was a 2. Greater than liver was a 3. And greater than kidneys or spleen was very intense. And interestingly, 90% of the patients in the NETTER-1 trial, the registrational trial for DOTA-TATE lutetium, were patients with Krenning score 3 and 4 on planar oxygen scan scintigraphy. However, the patients with a Krenning score 2 were included as well. So a Krenning 1 would be diagnostically significant, but not theranostically significant. The second problem, or the second question, the second part of the equation is we have to define the total disease volume. And then the first kind of thing that you might be asking yourself is, can we use the diagnostic to define the total disease volume? Can we hit 2 birds with 1 stone? We have one test and we'll define the disease volume on the diagnostic, and we'll define the positivity on the diagnostic. And if we can't do that, how should we define the total disease volume? So I don't think this question has been necessarily answered definitively, and I think there's probably pros and cons to different concordance tests. And I'm just going to dive into the PSMA concordance testing landscape just very briefly to give you an idea of the different strategies here. The most permissive, if you will, concordance testing in PSMA therapy is the German compassionate use. And in German compassionate use, clinical, it's more or less clinical practice in Germany. It's not under protocol, but it's also not commercially available for sale from a major pharma company. Each center kind of makes their own. They use PSMA PET-CT versus PSMA PET-CT. So the concordance testing is done versus the diagnostic and, of course, the CT component of the PET. So this has a lower screen fail rate. There's fewer patients that are excluded from protocols, but it also suffers from a little bit lower efficacy. The second most permissive is the vision trial concordance testing, which is PSMA PET-CT versus contrast enhanced CT and bone scan. And then the most stringent, probably the most stringent, at least the most stringent that I'm aware of, is PSMA PET-CT versus FDG PET-CT, which was first made popular, if you will, or first published by Michael Hoffman from Peter Mac in Australia. And this has the highest screen failure rate, but it probably also has the highest efficacy. To illustrate this concept, I'd like to show you a clinical case of a patient, not my patient, this was published in 2018. This is a PSMA PET scan showing extensive disease in the bone. And if you were to see this PET scan, you might think, well, this patient is a great candidate for PSMA therapy, lots of uptake in the lesions, and the lesions look very intense. Having said that, if I put the contemporaneous FDG PET on board, you'll notice right away there's a lot of disease in the liver that doesn't seem to be uptaking the PSMA ligand. So in a pictorial fashion, we can see that there's actually two types of disease here. It's polyclonality, the disease that can be targeted with lutetium PSMA, and disease that cannot be targeted with lutetium PSMA in the liver and in the hemipelvis. Michael Hoffman published using his FDG PET PSMA concordance testing, his first 30 patients. He had a beautiful waterfall plot of PSMA response where only one patient had no PSMA response, and 57% of patients met the 50% threshold for PSMA response. His updated data set of 50 patients had a 64% PSA response, but I will have you note that he screen failed 33% of his patients. So net 1/3 of the patients that were screened for this trial were not eligible for the trial based on PSMA-FDG discordant disease. So while his efficacy numbers are nice, there are a number of patients that do not qualify based on very stringent criteria for selection. Given his selection criteria and his quite, his very nice prospective trial led to the SNMMI Image of the Year in 2018. These are the 8 best responses. You'll see the disease, the metastatic disease in red, and then the follow-up study with the PSA underneath. So beautiful PSA responses, beautiful PSMA PET responses. These are the 8 best responses in Dr. Hoffman's trial. This led, I'm sure all of you know, to the registration trial, the VISION trial. This was a randomized controlled trial with gallium-68 PSMA-11 in previously heavily treated patients, previous taxane, previous novel androgen axis therapies, randomized well over 750 patients. I think the final number was close to 900, and they were randomized 2-to-1 to receive lutetium PSMA Q6 weeks plus best standard of care versus best standard of care with overall survival and radiographic progression-free survival as the primary endpoints, co-primary endpoints. This enrollment was completed in September 2019, and everybody here, including myself, is looking forward to the readout at ASCO in June 2021. I don't think anyone believes that this trial will be negative, given that Novartis and AAA are moving forward with the development of the molecule. To illustrate polyclonality, here's another PET scan. This is a patient of mine, DCF-PYL, very, very avid disease, lots of disease in the skeleton. And you might think this patient is a great candidate for PSMA therapy, but upon looking at the CT, you didn't actually need an FDG PET scan to identify large adenopathy with no uptake. The FDG PET was performed just for the sake of documenting that this patient's disease here was active, and you can see PSMA, very, very little uptake with intense FDG uptake in this adenopathy. This was the MIPS side to side, so you'll notice all the lymph nodes here have no or very little PSMA uptake. Even in the bones, there was a discordant disease in the bones, so the PSMA PET and the FDG PET are actually mirror images of each other, whereas you'd be hard pressed to see a difference on the CT between these two diseases. Another patient of mine with DCFP-YL and FDG, and I'll point you to this supraclavicular node on the right here, which is diagnostically positive on DCFP-YL on a PSMA targeted tracer, but theranostically negative, illustrated here by the blue arrow, the teal arrow. So again, different flavors of disease are in the same patient. Polyclonality is always a problem, or always a concern in a theranostic application. I think this is not really, I think this is not controversial. I think polyclonality increases with increasing lines of therapy as prostate cancer patients progress through ADT, second-line hormonal manipulation with abiraterone and enzalutamide and such, and specifically chemotherapy, docetaxel and cabazitaxel. We have increased polyclonality, and polyclonality is an enemy of theranostics. So this is definitely a strong rationale for applying theranostics earlier in the disease state, and I'm encouraged to see that AAA Novartis is moving forward with trials in hormone-sensitive prostate cancer, so pre-ADT prostate cancer. Very exciting. DCFP-YL and PSMA-1095, an iodine-targeted PSMA ligand, are another theranostic pair that are being evaluated by Progenics out of the United States. So this is DCFP-YL PET scan, and then dosimetry scanning in PSMA-1095, and you can see that lesion in the hemipelvis that concentrates the 1095 over the week of dosimetry imaging. So this patient went on to have a very nice PSA response. After one dose of 1095, he had an 82% PSA decline and a nice partial response on the PET scan. He ended up having an overall 95% best PSA decline and a progression-free survival of 9.5 months. So very nice response for a heavily pretreated patient. The beta emitters are not the end-all and be-all of PSMA therapy, and of Theranostics, lots of work is being done with the alpha emitters. So this was a nice paper from a Journal of Nuclear Medicine published by Dr. Cradwell from Germany, and he described a patient who was refractory to multiple cycles of lutetium-177 PSMA, but was treated with actinium PSMA as an alpha emitter, and after 2 cycles had a beautiful PSA response with an undetectable PSA and a complete PSMA PET response. I will draw your attention to the fact that this patient's salivary glands seem to have suffered in between the application of the lutetium and the actinium. So 3 cycles of actinium later, he doesn't have a lot of uptake in his salivary glands, and this is actually an ongoing problem. Patients are refusing further cycles of actinium PSMA based on severe xerostomia. Early work suggested that monosodium glutamate and perhaps botulinum toxin were going to solve the problem. Unfortunately, further work has shown that not only do you decrease the salivary gland uptake with monosodium glutamate, you also decrease the tumor uptake, so that's not a good thing. Intraglandular botulinum toxin is not really practical. It lasts too long, and it causes the same problem that you're trying to solve. You inject too much botulinum toxin into a salivary gland, you're going to cause xerostomia, so you're not helping the patient. So this is an ongoing problem, and I'm sure we'll be able to solve it. Radium-223 is not classically thought of as a theranostic, but I think it definitely meets the criteria for a theranostic. We're using technetium MDP and sodium fluoride as a diagnostic pairing to the therapeutic radium-223. What concordance testing should we use? Is there any concordance testing? So currently in clinical practice, there is no concordance testing to radium-223. However, there probably should be. This actually very elegant paper from Dr. Ahmed Zedafar at University Bonn was a retrospective analysis of a number of patients that he treated with radium-223, and it wasn't quite a randomized controlled trial, but it was almost a randomized controlled trial. He, as part of his routine, tried to perform PSMA PET on all the patients that were referred for radium, but some insurance companies declined the PET scan. In the patients who had a PET scan that was approved, he was able to demonstrate 44% PSA response. In unselected patients, that is, there was no PSMA PET scan performed, because the insurance company had declined to cover the cost of the PET scan, there was a 30% PSA response. And 13% PSA response is virtually identical to the 15 seen in ALSYMCA. And the ALSYMCA trial, the registrational trial for Radium-223, did not have any concordance testing. So the low PSA responses that we're observing with Radium-223 are probably related to discordant disease. In this patient illustrated here, you can see that the bone scan is focally positive and maybe a handful of spots in the spine, maybe the pelvis a little bit, but there's extensive bone disease which is active on PSMA PET, which you couldn't hope to target with Radium-223 based on its mechanism of uptake. So this may be a better way to do Radium-223, and of course we're going to wait for further validation of this if it ever comes. But I don't think Bayer is going to jump on this plan. SSTR Theranostics, gallium DOTA-TATE indium scan paired with lutetium-177 DOTA-TATE, as we've already spoken about. If you do concordance testing with FDG PET, which you don't have to, but we definitely do at this hospital for higher Ki-67s. In a monoclonal disease state, you'll have 4 possibilities. So DOTA-TATE positive, FDG PET negative. These patients will be candidates for PRRT, for DOTA-TATE therapy, and they'll have a good prognosis. DOTA-TATE positive, FDG positive patients will also be candidates for PRRT, but their FDG positivity will lend them to a slightly poorer prognosis. These are patients that will respond well to DOTA-TATE therapy, but unfortunately they'll relapse faster, and their overall they'll end up overall having a slightly poorer prognosis than the FDG negative patients. In DOTA-TATE negative, FDG negative, and DOTA-TATE negative, FDG positive patients, of course, these patients are not indicated for PRRT. So this patient is a nice example of a TATE positive, FDG negative, and this patient received the full 4 cycles of PRRT and did very well. Polyclonality, as is a problem with PSMA, is also a problem with DOTA-TATE. Theranostics, this is our patient who had lots of metastatic disease, lots of avidity. Unfortunately, on the FDG PET, we found some of his metastases were FDG positive and DOTA-TATE negative. Drilling down on the axial slice, you'll notice that this metastasis here, strong FDG positivity, and again, diagnostic positivity, but not theranostic positivity in this liver metastasis here. And this patient was not a candidate for PRRT in our estimation and was referred to other lines of systemic therapy. Sometimes you don't need FDG PET to declare a patient not a candidate for PRRT. This patient had metastatic disease on conventional imaging, CT and MRI, so we did the DOTA-TATE PET, didn't see very much. I'd like to go and find the disease on anatomic cross-sectional imaging and make sure that I'm not missing it. So we found this lymph node, which was static, and we found it again on the CT, and not enough uptake there to make this patient a candidate. Also, there's some liver metastases, which we didn't see on the PET scan, and therefore this patient was not a candidate for PRRT. Another little wrinkle in the story is, in the theranostic principle story, is our diagnostic scans, the question, I guess, are diagnostic scans infallible at predicting therapeutic uptake? That is to say, if a diagnostic is negative, does that guarantee that the therapeutic will be ineffective? And this is a case that I think is pretty rare, at least it's pretty rare in my experience, but illustrates the point that the diagnostics are not infallible. So this was a gentleman, a middle-aged gentleman in his 50s, who presented with a metastatic neuroendocrine cancer, and he had a big mesenteric mass and some mesenteric adenopathy all the way into the left supraclavicular region, which was intensely avid on gallium DOTA-TATE PET. Unfortunately, I guess as a complication, he also had new liver metastases on conventional imaging that were clearly growing and clearly metastatic, and we were not. There was no question in our minds that these were metastatic lesions, but we couldn't pick them out on the DOTA-TATE PET. And as hard as we looked, and some of these lesions were sizable, they were about 1 centimeter. The largest ones were just over 1 centimeter. We just couldn't find them on the DOTA-TATE PET. So we decided to do something which was a little bit maybe unusual, but we decided to treat him anyways. We said, you know what, we're going to treat this patient. And on the first 5-hour lutate planar image, the post-therapy image, I noticed a lot of heterogeneity in the liver. So we brought him back at 24 hours, we brought him back at 72 hours, and we did SPECTs, and we saw intense uptake in the lutate in the liver. So all these liver lesions picked up the DOTA-TATE. And we went back and we tried to find them on the gallium-TATE, and we saw absolutely nothing. So just to illustrate that despite the fact that these molecules are identical, there is some difference in the timing of imaging. Gallium-TATE is imaged, roughly at an hour, whereas lutate can be imaged a week later if you want to. So there is some difference in the timing of these images, and we were able to show that this patient was concentrating the therapeutic, and he went on to get his full 4 cycles of lutetium DOTA-TATE therapy. These are some of the important theranostic triplets, if you will. We can call them doublets, but they're kind of triplets in a will that I think are going to be with us for a while and increase our workload and help a lot of patients. So here we have the therapeutic, the diagnostic, and the concordance test. You'll notice a little bit of a flavor in the concordance testing. You're going to see CT, MRI, FDG, CT, MRI, FDG. And that's kind of where we're at in terms of the concordance testing. So I-131, we're using multiple different diagnostics here. Lutetium DOTA-TATE, if you have a PET scanner, you probably should be using gallium-TATE. If you don't have a PET scanner, Indemoctor is a good backup. Lutetium PSMA-617, so that's a very important therapeutic in prostate cancer, and gallium-68 PSMA-11 DCFPYL are going to be your diagnostic pairing. Radium-223, I think for sure this is a theranostic. Technetium MDP and sodium fluoride are your pairs, and gallium-68 PSMA question mark. This is not clinical practice in any way, but maybe it should be. And yttrium microspheres, which have a macroaggregate albumin as diagnostic, and I-131 MIBG, which we don't do too much of, at least at my hospital, but is still an important theranostic triplet. The future of Theranostics, where is the future going with Theranostics? I think the future with Theranostics is probably going to be, I think FAPI is going to be a part of the future of Theranostics. So FAPI stands for fibroblast activated protease or protein inhibitor. And this is out of Germany. The Germans seem to be working very hard on getting these new ligands and these new theranostics out. And so I think they're at FAPI 46 right now. There's 46 different FAPI molecules that have been investigated. And interestingly, FAPI seems to be malignancy site agnostic. So this was recently published. Breast, lung, colon, pancreas, you name it, esophageal, ovarian, all these tumors are FAPI positive. So right now the FAPI ligands are diagnostics are, I think, they're here, and the therapeutics are we need to get the residence time up and get the right molecules into the cells, and get the beta emitters to stick around and deliver the radioactive payload. So that's it. Those are my slides. I'm going to leave lots of time for questions. I hope a discussion after the fact. My take-home messages are rather simple. I think Theranostics in nuclear medicine is a growth story. I think it's here to stay. I think it's it's interesting, and I think we're going to be helping a lot of patients. Lots of money is coming in from pharma, so pharma is paying attention to this. The companies are waking up to the fact that this is real medicine and it's really happening, and we're fortunate to have lots of backing, lots of interest from industry. Theranostic principles are simple, but the devil is in the details, and no two patients are alike. So while the concept, it could be as simple as Richard's bomb. You see what you treat, and you treat what you see. No two patients are alike, and there's a lot of detail involved, and it's not as simple as it may look at first glance, but it's very interesting, and I encourage everybody to get involved in Theranostics if you have the opportunity to do so. So that's it. Those are my slides, and I guess I'd like to open it up now for discussion or questions.
Thank you very much, Dr. Probst, for that very clear, well-organized talk. Outside of the major centers in Canada, everyone kind of knows growth in Theranostics is coming. So it's always nice to see some expert opinion from Canada and kind of get an idea of where things are going. We do have a question here from Stephan Probst. The question is, does PSMA-FDG discordance mean we should exclude patients from PSMA therapy, or rather that we should use combined therapy, for example, PSMA plus chemotherapy?
So that's an excellent question, and I actually have an ongoing trial that is attempting to answer this question. We are enrolling patients, MCRPC, so metastatic castrate-resistant prostate cancer patients, with prospectively enrolling them with PSMA and FDG PET, and we're basically pre-therapy gonna slot them into 3 different categories of concordance. And so there's going to be the 100% concordance, the perfect concordance, the high concordance, and the low concordance. We set 50% as our threshold, and we're going to follow these patients and see if any amount of because the question always comes up, is any amount of discordant disease, like one PSMA positive, one FDG positive, PSMA negative lymph node, does that exclude you from therapy? So it's a good question. I think it's an open question. In terms of combinations, the combinations I don't believe are here yet, just because it's the toxicity, while the therapeutic efficacy might be multiplied, the toxicity might also be multiplied. So all these things knock on your marrow. So I would feel pretty uncomfortable giving, for example, 100 millicuries of I-131, 1095, and docetaxel. I'd be very worried for that patient's platelets and white blood cells. So the combinations are not there. The sequencing, however, is up for debate, and there's another trial called Pluto, which is funded by CCTG, that's going to be available, and that's pre-chemotherapy MCRPC that are going to be randomized to docetaxel versus lutetium-177 PSMA, and with a planned crossover design. So while the combinations are not actively being investigated, the sequencing is an open question that I think we should have the answer in a couple of years. That is to say, if you have an MCRPC patient, post-abiraterone, post-enzalutamide, should you offer that, assuming the patient is chemo fit, should you offer that patient docetaxel up front and save your lutetium for later, or should you offer lutetium up front and save your docetaxel for later? My personal prediction on this is that you're going to want to use your lutetium PSMA up front before all the polyclonality kicks in, because polyclonality is the enemy of Theranostics. With half of your disease is PSMA positive, the other half is not. Nobody thinks that's a good thing. So yeah, very interesting question. Combination, probably too toxic, or at least too toxic that I wouldn't try it. And sequencing, open question to be answered shortly.
Great. Anthony Ciarello asks, did you use FDG on the patient that was gallium-68 DOTA-TATE negative but Lutathera positive?
You know what? That is a very good question that I don't remember. I don't remember the answer to that. I was actually asking myself as I was putting together the slides. I thought to myself, did we bother to do an FDG PET on it? Now, to be fair, FDG PET can be falsely reassuring. So if the patient, for example, had a Ki-67 of 1%, it was a recent biopsy, those patients are FDG negative, and whether or not if there's no FDG doesn't exclude the fact that you have metastases that are PSMA negative, FDG negative. Like the double negatives can crop up. But that's a very good question. I'm gonna have to look that one up.
We have a question from Nada Almenier. Hello, Dr. Probst. Do you have any experience using the NET PET score published out of a group in India, which determines the eligibility of PRRT?
Yeah, so actually I came across this as I was doing some literature search for this talk, the NET PET score. So it's always something that I think you do, but this group formalized it. So they they assign numbers to it. So there's, I think we all do it in a way, whether you formalize it and you assign it a number. I think that everyone in the space is more or less is doing it. We don't assign a formal number, and we don't refer it to the net PET score during our term boards or during our reporting, our clinical reporting, for example. But we're doing very similar stuff in terms of looking at the disease using different tracers and trying to characterize the disease and trying to characterize any polyclonality, if there is any polyclonality.
Kathy Yip asks, how do you fund the therapy? Is there government funding in Quebec?
Okay, so a very interesting question. So Lutathera, which is the lutetium-177 DOTA-TATE, was in Canada, the landscape was every hospital was essentially doing it under protocol and funding it themselves, so to speak. So the hospital's budget would agree to pay for Lutathera. Now Lutathera has gone through phase 3, NETTER-1, the NETTER-1 trial, strongly positive, and it is Health Canada approved, it is FDA approved, it is EMA approved, and it is in Quebec reimbursed. It is reimbursed by provincial funders. So we got a letter from the INES, which is our Quebec funding body, that says, this is considered to be an approved therapy, and you should be offering it to your patients if you can. And we'll figure out the hospital, the hospital and the province figure out the money behind the scenes. But the message to physicians was, this should be offered. So there's provincial money there, and it's paid for. The PSMA ligands are not Health Canada approved, and until they are Health Canada approved, the provincial funders will not look at this. So Health Canada is step one, and once Health Canada comes in and says, we think this is safe and effective, and it's been proven to our satisfaction that this works and it's safe, then the provincial funders will get into a discussion with the manufacturers about pricing and about pharmacoeconomics. So until Vision is published at in this coming June, and until the AAA Novartis applies to Health Canada, none of the PSMA ligands are going to be funded. And everyone who's doing PSMA ligands is either getting them for free under protocol from a manufacturer, or buying the raw materials themselves, buying the lutetium-177, buying the PSMA ligand, putting it together themselves, and having the hospital pay for it, which is obviously not an expensive proposition.
Great. I have a couple of follow-up questions. So for the radium-223 therapy planning, do you use MDP or sodium fluoride? So
we actually don't do very much sodium fluoride. We do exclusively MDP at my hospital. We've done a handful of sodium fluoride patients, and our PET scanner is pretty busy doing FDG, so we didn't necessarily. I don't know. We weren't dying to. We could buy sodium fluoride. We weren't dying to switch over to sodium fluoride. So we're doing MDP for everyone, and sodium fluoride very, very, very rarely for a special case.
Okay. You alluded to it a little bit with the salivary gland, but can you use the diagnostic scans to predict side effects with Theranostics, for example, renal impairment or something like that?
Yeah, I think you can. And most of the salivary gland problem that I alluded to, most of the work that was done with the salivary glands with, for example, monosodium glutamate and botulinum toxin, most of that work was done with the diagnostic molecules, was done with DCFPYL and gallium-68 PSMA-11. So when people were working on not making sure that lutetium PSMA didn't, or actinium PSMA didn't destroy your salivary glands, the work was actually done with gallium-68 PSMA-11. So I definitely think that there's a predictive, even though as we saw it's not perfect, there's a very, very strong predictive value of the diagnostic for the therapeutic, and that goes for malignant tissue and benign tissue. So while you can't necessarily predict renal failure based on uptake, you can definitely, you could predict how many gray the kidney would get, for example. So then you'd have to extrapolate to, okay, well, if this kidney gets X gray, is it going to push the patient over into renal failure? So yes, I believe that to be strongly predictive, if not perfect.
Okay. And one other question, we use in Edmonton, we've been using for a few years F-DOPA for a variety of indications. We have noticed, since we started using DOTA-TATE at our cancer center, there are a few patients that seem to have F-DOPA avid disease, but that are negative on the DOTA-TATE scans. So, everyone talks about FDG in terms of concordance and discordance, but have you ever heard anything about F-DOPA, DOTA-TATE discordance? I mean, they're both have reported high accuracies for neuroendocrine tumors, but I've never seen about that.
Yeah, so that's an excellent question. I have zero experience with F-DOPA, so I'm going to answer theoretically with having never read or nor done this myself. But I would say if your disease volume is best defined with F-DOPA, like if you trust that F-DOPA is defining disease volume, active disease volume, that is then DOTA-TATE negative, then that would count as discordant disease, right? So I think that, I guess I don't know the sensitivity and specificity of F-DOPA PET because I don't do any F-DOPA PET, but if the sensitivity and specificity are through the roof, 99% hypothetically, and I see significant disease volume that is, positive on F-DOPA, active disease, negative on my DOTA-TATE PET, that would be discordant volume for me and count against my concordance fraction score.
Right. But you've never heard of any direct comparisons of those two, because I haven't.
No, I am not. I can't. I am complete ignorance. I have not dived into the F-DOPA literature, so I can't speak intelligently about F-DOPA. I've heard good things, but I can't tell you more.
Yeah, I just know in some other diseases they talk about discordance with F-DOPA using FDG as well. So for example, neuroblastoma, there's some literature suggesting you should be doing FDG and F-DOPA to look for discordance. But, I just wonder what happens if you have discordance from two two tracers which are supposed to be taken up in disease, which is well differentiated still.
Yeah.
But anyway,
yes, an area for further research.
Yeah, exactly. Okay, I think that's it for our questions this evening. I think Nicola has some concluding statements.
Absolutely. I just want to thank Dr. Probst for his presentation, very concise. I want to thank you, Dr. Aberle, for your moderating duties tonight. Thank you, everyone, for participating as an attendee and all the questions that were asked. Evaluation form and credits. It will be sent out to you, and then you will be sending out the evaluation back to us, and you will get your certificate of participation after that for your CME credits. The webinar will be available online for reviews. There will be a link attached where you can view it. And our next session will be actually a little bit more of a month. It will be the 17th of April, the day-long conference. It's going to be on a Saturday, a bit of the same that we did it back in November. So stay tuned. You'll get some more information on that. Again, thank you, gentlemen, for a great night, great presentation. Thank you very much. Have a great night, everyone. We'll see you into the next webinar in April.
Good night.
Have a good night.